Well, hi there, and good afternoon. It is 4 o'clock in the mountain time, which means 6 o'clock on the East Coast, and of course, 3 o'clock for our friends on the West Coast. And that means only one thing on a Tuesday afternoon. It is time for Fertility with Fink and Friends. I am Fink, you are Friends, and we are sure glad to have you here. Thanks so much. Live from Colorado Springs, where I am the clinical director of IVF services here at CNY Fertility Colorado. I am also the medical director at CNY Fertility in the Miami Center of Excellence in South Florida. Hi to everybody. Hi, Mayeli. Hi, Kirsten. Oh, look, it looks like my own mother has actually been able to figure out how to get on Instagram here. So a special shout out to Harold and Emily in beautiful Southern Alabama, in LA, Lower Alabama. Hi, Haley, and let's see who we have over here on the CNY side. Well, now we've got Naomi, we've got Estella, we've got Athena, we've got, boy, the list just keeps going on. It's 10 a.m. Wednesday in New Zealand. So we are live via satellite internationally. So hi, CNY Nation and CNY World. Good to see everybody today. How's your week been? It's been another quite a week over here at CNY Fertility in Colorado. And it looks like Caitlin is in Colorado Springs for her transfer. Our fingers are crossed for you. And it looks like, oh, Jasmine is telling me that she cannot come to Colorado because I guess because of an insurance thing. So actually, you know what? Let's talk about that. There is one particular insurance company who will not accept my board certification. And so nor do they in Buffalo. So the only CNY facilities that they will allow are in Syracuse and Albany. So sadly, that means that some people will, if they are able to use their insurance, will not continue to be able to come to Colorado. Hopefully that insurance company will figure itself out and make some changes there. In the meanwhile, gosh, I started to say things about, I wanted to talk a little bit more about courage. And if you recall, a couple of weeks ago, we talked about my friend Elon and his brain surgery that he had to have, and how the courage it must take to be able to face looking into your own brain. And, it's given me cause to think, does it make, is it any necessarily different a scenario to think about the kind of courage it takes to face a fertility problem? Because we are taught from a very young age that we are supposed to be procreating. It's evolutionary program, but little girls play with dolls. Sometimes little girls get in relationship with other little girls, and in fact, that the normal way that's supposed to happen just doesn't work. But even in heterosexual couples, there's this societal pressure that says we need to be procreating, and when it doesn't work the way it's supposed to, this can create great frustration. It can create great strife in a relationship, and the need to perform at a certain time. Oh my God, get home. We have to have sex right now because I'm ovulating. Does that resonate with you? Has that happened in your house? Well, that's not such an easy thing to kind of deal with. And when that happens, we have to be faced with courage. Fear is the worry about what is going to happen tomorrow. And that's kind of really the difference between anxiety and depression. If you think about it, depression is when we are preoccupied with thoughts about what happened in our past and how they affect us today. Anxiety is typically worries about what's going to happen tomorrow. And that's really where the fear comes in terms of fertility. What's going to happen tomorrow? Am I going to be able to have a baby? Maybe I had a miscarriage. Am I going to be able to get pregnant again? Every day that goes by with that miscarriage, or after that miscarriage with a subsequent pregnancy, leaves us wondering and worrying, anxiety about what's going to happen tomorrow. Courage is not the absence of fear. Courage is the ability to face that fear head on. It's the ability to look fear in the eye and say, I have the ability to overcome this problem. And that's really what we're here to help you with. What's amazing to me is to even think about the very practice of gynecology and how it has evolved over the 25 years that I've been doing this, and how things have changed. It used to be that a hysterectomy, taking the uterus out, was really the major treatment option for almost every type of gynecologic concern that could happen. Bleeding problems. Well, if you're done with it, just take it out. You don't need that uterus anymore. Well, now there are so many minimally invasive solutions to complicated problems that we don't have to think in terms of such grandiosity. And in terms of fertility, we have come such a long way. The science, while it's not perfect in what we do in fertility, and gosh, I sure wish it was, it has come so far that now we can really offer hope to just about everyone. So there's always going to be some kind of solution. Let us help you find your solution. And that's what courage is. It is looking that fear in the face and saying, I can overcome you, even if you have to ask for help. So that's my inspirational message of the day. And hi to Serena over here, and hi to Amber. Thanks for being with us as always. Let's see, what else did I want to talk about? Oh, here's an important thing. It's a Pride Month, if you weren't aware. We at CNY are very proud to be supporters of the LGBTQ plus community. And both this week and next week, we are hosting a special webinar for our LGBTQ friends. Coming this Thursday, Brandis Montez, our nurse practitioner here in Colorado Springs, will be hosting an event that will talk about all the different options for treatment, and how LGBTQ families can expand their families and create children. Everything from reciprocal IVF to things about sperm donors and egg donors for both males and females. Really a broad and general overview of what your options are for building a family. And then next Tuesday, after, I believe about a half an hour after we finish Fertility with Fink and Friends, we will be also doing a live webinar talking specifically about reciprocal IVF. And reciprocal IVF is one of the coolest things, honestly, that we do. And that's where we take an egg from one female partner, create embryos with donor sperm, and place that embryo back into the other female partner, so that two wives, one can carry the baby using the other wife's genetic material. That's called reciprocal IVF. Both of these programs you can register for by looking at Instagram. Under the bio on the CNY Instagram page, in the bio portion, there is a link to register for both of those webinars. Again, one is this coming Thursday with Brandis. The other is next Tuesday with me. And please tell your friends. It's really interesting stuff, and it's stuff that we are absolutely delighted to be able to help with. So that said, let's see what we have in terms of questions. Yes, and Serena and Serena and Amber have a really wonderful story together, which I'm hesitant to tell because I didn't ask specifically if it was okay, but we'll hold that off for next time. Maybe Amber will give me permission to talk about the magic that's going to be happening between the two there. So thank you both for being here. Grace, Hannah, nice to see you. And looks like hopeful in 2023. I have endometriosis and am planning to do a frozen transfer in the next few weeks. Should I do medicated or natural? Okay, so this is something that we talk about a lot, and I'd like to just review it for you here. You have the option when you create a frozen embryo, or when you create embryos and you freeze them, you have the option of doing a medicated cycle or a natural cycle for a frozen embryo transfer. What does that mean? And by the way, this is something that you can request yourself. If you're already a CNY patient, you do not have to have a provider consult where you get these orders in place. You can simply ask for it through your nursing team. The medicated cycle is the standard cycle that has been done since IVF was invented. Right. So this has been around for a very long time, and is kind of just the way it was always done. Now we're finding maybe there's some alternatives, but in that medicated cycle, you get typically 6 to 12 days of estrogen, followed by another ultrasound to show that your uterine lining is thick enough. And then you get 6.5 days of progesterone in oil, the shot that goes into the butt. Everyone's favorite endeavor in the IVF world is the progesterone and oil shot. It's no fun. But your body needs that extra progesterone because in the medicated cycle, we are really controlling every aspect of your hormones. There's really nothing that's left to variability. We're doing controlling everything. So 6 to 12 days of estrogen thickens the lining, 6.5 days of progesterone, you get your embryo transfer, and then you stay on that progesterone in oil leading up to about 10 weeks of pregnancy, which is the point at which the placenta will take over. That's a medicated cycle. And let's see what we have here. Yes, Dr. Fink is the one speaking. That's an interesting question. Hi. In a natural cycle, we let your body contribute your own hormones to the equation. So it means that instead of suppressing the ovary and stopping you from creating a follicle that you will then ovulate, we want you to create that follicle. And that can be done in one of two ways. If you have regular periods, we just let that happen naturally. Let your body do its own thing. You make a follicle just like you do in every other cycle when you're going to have a period. That follicle makes your estrogen. That estrogen thickens your lining. We typically like to follow the size of the egg in the ovary, that follicle, and trigger the ovulation when the time comes because it gives us a little bit more control over the timing of when you'll have your transfer. When the ovary releases the egg, then you start making progesterone. And that progesterone is what supports the pregnancy. We give you some extra progesterone, but in the form of a vaginal suppository. So rather than having to get the PIO, the progesterone in oil shot, you can do this just by placing a little pill or a little vaginal insert with some local effect of the progesterone to help to maintain the lining. That's a natural cycle. There's something that's called a modified natural FET, and that modified natural happens typically for people who don't ovulate on their own. So people with polycystic ovarian syndrome, we can give you some letrozole, which is an ovulation induction agent, to get you to create an egg that you will then be able to release. In my personal opinion, I don't like to use letrozole in people who don't need it. So if you have a regular period You can do a natural cycle without using the letrozole. And I would encourage you not to, because it's just one more thing to kind of mess with the natural hormones. Our staff often likes to give people letrozole, and that's a debate for another time. But if you have a regular period, you don't need that letrozole. And this is something that you can ask our team about. You can ask the nursing team about a medicated versus a natural cycle. Again, you don't need a consultation. But going back to the original question for Hopeful in 2023, with endometriosis, is there a benefit to doing medicated versus natural? And the answer there is no, there's no data that shows that one is better than the other specifically with endometriosis. However, that said, the natural cycle has a little higher pregnancy rate. It has a little lower miscarriage rate, and it has a lower risk for certain types of pregnancy complications that happen later on in the pregnancy, specifically blood pressure type complications of pregnancy. So in general, if you can do a natural cycle, I would recommend a natural cycle. Looks like I can't quite read it. Sabo Snip by Think 3Z. Most fertility issues are fixed with diet. Is that a first route of treatment? Well, I'm not sure that I can say definitively that most fertility issues are fixed with diet. It's a bold statement, but many issues with inflammation can be fixed with diet. And so if you're familiar with Dr. Kiltz's work in keto and carnivore, that is predicated on the idea that inflammation is one of the major causes, certainly is one of the major causes of disease, but is one of the major causes of infertility. So certainly by addressing diet, that may be something that can lead to improved fertility. So absolutely, it's worth looking into. If you're not familiar with Dr. Kiltz's work, I would say take a look. He's all over the internet, and that is a good thing. Okay, let's see what else we have here. Looks like Nikki. Hi, Nikki. Which insurance? Hard time getting insurance. Well, you know what? We're going to skip the talk about insurance here. So, looks like Nivi Synthil, I believe that says. I'm sorry if I'm mispronouncing that. How can we do a modified natural transfer after Lupron suppression? So folks with endometriosis will often be on medication in order to suppress endometriosis. The data shows us that 60 days of suppression of endometriosis can have a benefit on improving transfer outcomes. So we will often use either Lupron, or we will use a medicine called Orilissa, or we will use a medicine called Myfembree. And these all turn down the volume knob on endometriosis in the body. And therefore, it allows the brain to talk more clearly with the uterus as it pertains to implantation. So, Lupron shuts down all the hormones. And so one of the concerns is that when you're coming off Lupron, it may be a little bit of time before your hormones line back up to normal and allow you to ovulate in a normal, predictable fashion, which is really what's required in order to do a natural cycle FET. So in that scenario, I would say you can either wait 1 month. So Lupron Depot, which is a question that was asked, is a medication that will last for 3 months. It shuts down the hormones for that full 3-month period. You can wait a month and resume normal cycles and then do a natural cycle, or you can go directly into a medicated cycle after finishing the Lupron. And that's a situation where I do think a medicated cycle is probably beneficial, because waiting, well, the longer you wait, the greater the probability of that inflammation, as we talked about, starting to come back. And so maybe a medicated cycle after Lupron might be a little clearer way to proceed there. Um, let's see. Good afternoon to everybody. Chloe's baby journey, CNY Colorado gave me my baby. Oh, that's really wonderful. I did the retrievals, and our former doctor here did the transfers. Chloe's baby journey got Chloe a baby. So congratulations, and same to everyone who has been able to. Um, um, Score that positive pregnancy test. Ms. Y. Gracie says another month of not being able to start due to an elevated FSH. Is there anything I can prime with to help get it down so I can start? So you raise a great question, and that has to do with what we call priming. So an elevated FSH, the FSH hormone, is the hormone follicle stimulating hormone that comes from the brain that tells the ovaries to produce follicles or to make eggs. As we mature and get closer to the menopause, the FSH number starts to go up because there are fewer eggs to feed back. And so, therefore, the brain is trying harder to get us to make eggs in order to make estrogen, because that's really what those eggs do on a regular, ongoing basis. The cells that line the follicles are called, let's see if you remember this, because we've talked about this before. Those are called granulosa cells. Those granulosa cells make estrogen. So estrogen is what's talking back with the FSH hormone. When the estrogen level is high, there is less FSH. When the estrogen level is low, it's telling the brain, oh, we need more estrogen. So make more of that, would you, so that we can make more follicles and make more estrogen. Well, in fertility, that's an important feature. We want more follicles because we want to be able to get more eggs. If the FSH is high, it suggests that there is a lower ovarian reserve. There may not be as many eggs left. And that FSH, as I said, goes up as we start to approach the menopause. So sometimes priming or doing some sort of medication to talk to the ovaries can get that FSH to drop. It also convinces the ovaries, estrogen and progesterone, for instance, this is the language that the ovaries speak. So by using some estrogen, you will send a message to the FSH that's going to lower that level. So priming with estrogen and progesterone is probably the best thing you could do there, Miss Y. Gracie. And we'll wish you all the very best of luck. Zev is asking, my partner and I want to know if we can get a surrogate, or what we call a GC, a gestational carrier, is a slightly different term, through CNY. The answer to that is yes, we do have a donor team that can help you. And feel free to reach out to us and we will get you in touch with the donor team. That's a great time to actually plug Brandis's talk this coming Thursday. And again, take a look at the bio portion under the CNY fertility logo on CNY's Instagram side, because that's where you can register for that program. In about 30 minutes, you can learn everything that you need to know about the options that we have for gestational carriers or surrogates, donor sperm, donor egg, everything that we can do to help everyone get a family. So let's see what else we have here. I am going to say hello over here on the Facebook side, which I neglected earlier on. And here we are 25 minutes into the program. I didn't even say hello to Facebook. So hello, Facebook. We've got Raza. We've got Anyi. Hello. Morgan is saying, I have a luteal phase defect, about 9 days from ovulation to flow. Doing IVF this summer, wondering if the luteal phase defects impacts anything regarding the IVF process, either retrieval or transfer. Let's talk about what some of that stuff means, because you hear that terminology, and just to make sure we're all on the same page. So the beginning part of the menstrual cycle is called the proliferative phase. So the proliferative phase is the time at which your ovary is producing an egg or a follicle that we see in the ovary, and we follow that follicle size. It gets bigger and bigger until it reaches the point where you will release the egg, and that's ovulation. After you ovulate, you enter what's called the secretory phase or the luteal phase. Now, the first half of the menstrual cycle can be quite variable. In a standard 28-day menstrual cycle, it's a 14-day proliferative phase and then a 14-day luteal phase. But in people who have shorter or longer cycles, typically it's that first half of the period, the first half of the cycle, that's variable. It can change. It can go sometimes instead of 14 days, it might be 10 days or 9 days or 8 days. The luteal phase is usually fixed, and it's typically 14 days. So if you get a period, you can count back 14 days from the day that you got that period, and that will, generally speaking, determine the day that you ovulated. Right? Well, a luteal phase defect usually means when someone has a shorter or longer luteal phase, because again, it's usually pretty fixed. So in Morgan's situation, Morgan has an issue where it's 9 days from the time she ovulates until the time she gets a period. And that's called a luteal phase defect. And it means that the lining of the uterus gets confused. It's not sure what it's supposed to do. It may not have enough time in order to be able to get stable and to implant a pregnancy. With IVF, that problem is overcome. So, Morgan, you can rest assured that when we do this, we're getting eggs, we're making embryos, and we can really control all of the timing of implantation. Once we've made those embryos, we can control every avenue of how you make the egg, how the embryos are made, and ultimately when those embryos are put back. So the luteal phase defect should not stand in the way. Looks like Danielle is asking, is it safe to take baby aspirin after transfer? And I would say the answer to that is yes. So baby aspirin is one of those interesting things because it's really the only intervention that has been shown, the only intervention in the general population that's been shown to decrease the risk for blood pressure complications, specifically something called preeclampsia later on in the pregnancy. So certainly folks who have a history of preeclampsia in a prior pregnancy, we will often put on a baby aspirin because it does decrease the risk for preeclampsia recurring with their new pregnancy. So yes, you can take baby aspirin afterwards. Jennifer's here on Facebook as well. I turned 44 a few days ago. Happy birthday, Jennifer. I hope you celebrated in a grandiose fashion. Is it a waste of time and money to try IVF with my own eggs? Well, I would say, listen, it's ultimately a judgment call. Is it a waste of time and money? It is certainly an uphill battle at 44. Now, I had a conversation a little earlier today, not that long ago, in fact, with a patient who was 44, who had an AMH. Her ovarian reserve hormone was very, very good, certainly higher than average for most people who were 44. And what does that mean? Well, that means that the ovarian reserve, the number of eggs remaining in the ovaries, was pretty good. The problem is that the DNA in those eggs starts to lose stability as we age. Right. And that's the reason that it just gets more difficult for us to have babies as we become older parents anyway. That's why even in nature at 44, it's difficult for you to get pregnant. But there are some things that you can do. So the process of IVF without doing anything different would give you about a 1% or less chance of being able to achieve a pregnancy at 44. So you might say, well, geez, that's hardly worth going through the process. Well, there are some things that we can do. We can do some priming. There are a list of supplements, and this, gosh, I think I mention every week. You feel free to Instagram me at RandyFinkMD on Instagram, and I'm happy to send you the list of supplements. They come from the book. It starts with the egg, and this kind of really reviews the evidence, the data behind the biochemistry of supplements and what vitamins can do for fertility and reproduction. We can turn the clock back somewhat on egg quality by really working on what's going into our mouths. That's one way that nutrition can help, but nutrition can't do everything there. I am a firm believer that supplements can make a huge difference in egg quality across the board. So it's not just for folks who we call of advanced reproductive age, but really for anybody. So if you'd like that list, please reach out to me and I'm happy to share it. You can also read the book. It starts with the egg. We pulled out the list and found the right doses and found the right formats and found some reasonable prices there. So I think that is probably worthwhile doing. What some people, Jennifer, will opt to do is to do what's called a donor egg backup. And so when we start to reach the age where it is more and more challenging to create normal embryos based on our own genetics, based on our own DNA and the stability of that DNA with age, is that some folks will do an IVF stimulation with their own eggs and have purchased a cohort of donor eggs that they can fertilize at the same time. And it gets a little less expensive to do it that way than it is to do your own cycle of IVF and then separately to end up using a package of donor eggs. But what happens then is that we have your eggs that we retrieve, and we have the donor eggs, and we fertilize them all with the partner sperm, so that one way or the other, coming out of that cycle, you will have embryos that have a good probability of being able to get you pregnant, whether that is coming from an egg of your own or from the donor eggs. It just opens things up to increase the probability of getting pregnant. Let's see what else we have here. Let's see. We got some political questions here, and we're going to skip the politics for the evening. And hi to Brandy Lynn on the CNY Instagram side. My CNY baby just turned 2 months. Gosh, I still love listening to these lives, and we still love having you. Thank you so much for being here, and congratulations. Please send us pictures because, gosh, we live to see those things. Let's see, this comes from Simply Ayoka. Hi, I have 2 normal frozen embryos. Should I transfer both? Well, so the question that you're really asking, you say that one is poor and one is fair. So when you say normal frozen embryos, are you meaning, I don't know if you mean that they are PGT tested embryos, because there are a set of guidelines that we follow and we recommend that you follow as far as embryo transfers go. And you can look that up on the internet. It's the ASRM, the American Society for Reproductive Medicine, the ASRM guidelines for embryo transfer. If you have a tested embryo, that's an embryo that has undergone PGT testing and is known to be euploid or to have normal chromosomes. Some people call that a normal embryo. So that's why, Ayoka, I'm not sure exactly what you mean there. But if it's a tested embryo, the recommendation is always that you transfer one. Why is that? Because the odds of getting pregnant with a euploid embryo, it's about 60% probability with a euploid embryo. That's the highest chance of success we have with IVF. We don't want you to have twins. Twins is in general not considered to be a good thing because it increases, sometimes even dramatically increases the risk to pregnancy. So with two euploid embryos, it increases the probability of a positive pregnancy test, but it actually barely increases the probability of a live birth, which means that it increases the probability of pregnancy loss. So that's something obviously we really would like to avoid. Now, if these are a poor and a fair embryo, and these are day 3 embryos, for instance, depending on your age, sometimes even within 3 or 4 embryos may be within the guidelines. And so hard to answer that question there, my friend, without knowing more information. But take a look at the ASRM guidelines for embryo transfer, easily available on the internet. And well, that will help you to kind of understand where we stand on embryo transfer. Let's see, here's a question: how accurate is a sneak peek result at 6 weeks? Well, so I think what you mean is how accurate is ultrasound in a 6-week pregnancy? Well, at about 6 weeks, we ought to be able to see a heartbeat. That heartbeat may be difficult to see, and the heart rate may still be lower than what we expect it to turn into by about 7 weeks. And a low fetal heart rate is often associated with a chromosomal abnormality with the pregnancy. So if we do an ultrasound that's right at 6 weeks and the heartbeat looks low, we'll usually have you back to check that heartbeat again. But if you see a viable intrauterine pregnancy with a heartbeat, we know that 95% of those pregnancies will continue on. So how accurate is that? I'd say that's better odds than what you get in Vegas. So yes, that's in general a very good thing. Sissy 1604, hi, good evening and welcome. By the way, 37 minutes after the hour here. Boy, the time is flying. You're on with Fertility with Fink and Friends, CNY Nation. I'm Dr. Randy Fink from Colorado Springs. Sure is nice to have everybody with us tonight. We're here every Tuesday. So if you can't get your question answered tonight, please, by all means, come back next time. We try to get to everything, but getting a lot of great questions here. So doing our best. And hi, amazing Javier. I like that name. Hello. All right, Sissy, after 2 miscarriages and 4 failed IVF, I'm trying intrauterine PRP for a thin endometrium. Is that likely to help? And my answer to that is, yeah, probably so. PRP is platelet-rich plasma. And what does that mean? Well, it means that we take a tube of your blood, separate out your body's growth factors, your tissue factors, things that are healing to you that normally live with your platelets. Now, in a standard tube of blood, when we take it and we spin it down, what ends up happening is that the platelets disappear along with the red blood cells. If you've ever seen a tube of blood that's been spun down, you've got a big bunch of red blood cells at the bottom and some clear or yellowish stuff at the top, the serum, the plasma at the top, and the red blood cells at the bottom. Well, with PRP, there's something magical in that tube that we use, and that's where the sort of intellectual property of PRP is. It's in the tube that separates out the top from the bottom components of the blood. And so rather than letting the platelets and all their magical properties disappear into the red blood cells, they stay in the plasma. And we can draw that plasma off and do lots of things with it. It's used in orthopedics. It's used in joints to inject into a sick joint. It can be used, it's very commonly used in aesthetic medicine. It's used in the face. It can help you grow hair. I'm like, well, let me just, maybe we should do a live demo about hair growing. And in the fertility world, it's used in a couple of different ways. So we can use PRP in the ovaries, which may be able to help folks with egg quality issues. It's intra-ovarian PRP, which is still considered experimental, but I have seen some great results from it. And certainly it can be used inside the uterus, intrauterine PRP, which helps to boost the uterine lining and help that lining to just become healthier. Think of it as the best salve that your body could ask for. And the best news about it is that it's all coming from your own body anyway. So you're putting your own tissue back into your body, and it really can do some amazing things. So Sissy, yeah, I would say that's a really good idea. We call that a PRP wash. And we do offer PRP wash before an embryo transfer. I consider that particularly valuable for folks who have had recurrent pregnancy loss, because again, it just makes for a healthier endometrium. Let's see, Kirsten is asking, 2 embryos left, suspected endometriosis and adenomyosis. Is it best to treat it before an FET or to actually test before treating? Well, if you know, so adenomyosis is something that can specifically be diagnosed by imaging, and adenomyosis is where the lining of the uterus, the glandular lining that makes up the inside portion of the uterus, that's that part that really becomes your baby blanket. When we do your embryo transfer, we're placing the embryo into that uterine lining. And of course, that's the part that sloughs off if the body realizes, we're not pregnant. We need to clean it out, try again fresh next month. And that's the signal to have a nice normal period. Well, adenomyosis is where the glandular portion of the uterus drops itself down into the muscle. It's like dropping a well into the muscle. And of course, most of the uterus is made of muscle, and the job of that muscle is to squeeze the baby out when that time comes, right? Adenomyosis is a dysfunction of that endometrium, or the glandular lining, that is dropping down into the muscle and can result in impaired muscular tone, impaired blood flow, and even a sick endometrium. Endometriosis, as we talked about, is that uterine lining that, rather than sloughing off, works its way up and implants into the abdominal pelvic wall and along with the pelvic organs, and then interferes with the way the brain is talking to the uterus. So adenomyosis can explicitly be diagnosed by imaging. It can sometimes be seen implied with a simple pelvic ultrasound, but also MRI is very sensitive to diagnosing adenomyosis. And endometriosis, if there's a collection of endometriosis in an ovary, which is what we call an endometrioma, then we can see it there. But otherwise, endometriosis requires either a laparoscopy to diagnose, or the non-invasive test, which is called Receptiva, which I happen to think is a very good test. If we know that you have endometriosis, endometriosis doesn't always impact the ability of an embryo to implant. There are plenty of people who have endometriosis who get pregnant on their own without having to go through any of this business here in the fertility world. Now, some people have endometriosis and it does stand in the way. And if we know that it's standing in the way for you, Kirsten, then treating that endometriosis beforehand does improve the outcomes of an embryo transfer. And the same can be said for adenomyosis. So I think it's an individualized decision, and it's based on a lot of factors. But so I would say, yes, I think that's worthy of considering. Hi to, I think it's Priya Wheeler. Nice to see you this evening. What caused an AMH level to rise? Good question. 34 years old. The AMH increased from 4.8 to 6.2 in 1 year, still having a low follicle count and a failed FET. Well, when the AMH, or the anti-Mullerian hormone level, is above about a 5, we start thinking about polycystic ovarian syndrome, or at least what we call polycystic ovaries. And that may mean, so the syndrome of PCOS, as we call it, requires several different things to meet the criteria. You have to have some issues with your male hormone levels, with testosterone, your androgen levels. You may have some acne, some hair growth, chronic anovulation, that you chronically don't release an egg. And you have generally a characteristic appearance on an ultrasound that looks like, it actually looks like a ring of pearls on the ultrasound, that here's the ovary, and we see follicles in the ovary that literally look like a little kind of necklace that you would wear that's made of pearls. That's PCOS, the syndrome. But there is also just kind of what we call PCO, or polycystic ovaries. And that can be anybody who has ovaries that are going to respond in a similar fashion to what we would expect from polycystic ovarian syndrome. They typically respond very well to stimulation, although sometimes they don't respond at all. It takes escalating doses of medication to get a response from the ovaries. So the first thing I would say, if you're looking at an AMH that has gone up over time, one, was it the same laboratory that ran the test? Because these labs are not integrated with one another, and what they call their normal reference ranges, it may be apples and oranges, kind of trying to make a comparison there. So that would be my first thought. And the second thought is, well, the other things that go along with polycystic ovaries, things such as insulin resistance. If your insulin resistance has worsened over time, that may cause the AMH to rise. So hopefully that is an answer that helped you today. Vitamin recommended for uterine receptivity. So there is actually a whole protocol of vitamins for receptivity that's associated with embryo transfer. So that's coming from also from Sissy. Sissy, do you, if you would like to Instagram me here, Randy Fink MD, I'm happy to send you that protocol. Typically, it's a prenatal vitamin. It's some DHA, it's vitamin D, it's vitamin E. CoQ10 is always helpful. And the one that everyone always forgets is L-arginine. L-arginine. And we'll probably talk next week a little bit more about some of these supplements. But L-arginine is the one people forget. It is not something that I would like for you to be using if you are doing an egg stimulation, if you're doing IVF stimulation process, because it can actually decrease the number of eggs that we get in a stim cycle. But it is important for embryo transfer. Again, happy to be able to send you that list. Is it a good idea, coming from Felicia, to add PIO injections in a natural cycle? The answer to that is no, it's really not necessary, Felicia. You can do it if you want to. And for whatever reason, I've talked to several people over the last, a few days who really wanted, or for that matter, even insisted on adding progesterone in oil with their natural cycle. But because the ovary is making so much natural progesterone when you ovulate, in most cases, the PIO is absolutely not needed. Now, just because we're talking about a natural cycle doesn't mean that we just leave everything to nature. No, not at all, because we are going to be testing your hormone levels. And if it looks like we've got a problem with progesterone, we will supplement that progesterone, and if necessary, use PIO. However, as a general rule, progesterone in oil is not needed with a natural cycle. Tiffany is over here on Facebook. What is the best method, natural, modified, or medicated, for someone who has a period but does not always ovulate or release an egg? So, Tiffany, if you're talking about best way to do a frozen embryo transfer cycle, I would tell you, if you are prone to not ovulating, right? If you are prone to, well, periodically, then you'll just kind of have some bleeding, but we can't prove that you're ovulating. The very straightforward answer to that, my friend, is that's when you add letrozole. So 5 days of letrozole is called ovulation induction and will get you to release an egg. So when you make that egg and release that egg, then that's what's called a modified natural FET cycle. So if you are not a releaser of eggs, or that it's just not that it happens, infrequently, irregularly, or I should say unpredictably, that's the indication to use the modified natural FET. Kayla, hi Kayla, is asking, is N-acetylcysteine something that is beneficial? The answer is yes. N-acetylcysteine is a supplement that is on the list that comes from, it starts with the egg. And again, I think maybe next week we'll probably devote some time specifically to talking about what the supplements are that are on that list, and what kind of doses, what they do for you. But yes, NAC, or N-acetylcysteine, is a supplement that is recommended both for those with normal ovarian reserve and for those with diminished ovarian reserve. Let's head back over here to the CNY Instagram side. What is the difference? And this comes from Jody Ann Sharkey. Hi, Jody Ann. What's the difference between a fresh embryo transfer? An embryo transfer or a fresh transfer and a frozen one. Okay, so let's say that you undergo IVF. And we get some eggs and we make some embryos. Well, we can take those embryos and we can do several different things with them. We can do a fresh transfer, which is where we take that embryo and place it back inside of you, the same cycle as you've done your stimulation. That's a fresh transfer, or what we call an ET, an embryo transfer. That's a fresh transfer. Now, let's say that you have 10 embryos. And we place one embryo back inside of you. What do we do with the other 9 of them? We freeze them so that that stops them in time. They hang out, they wait for you until you're ready. Let's say that you get pregnant with that fresh transfer. Well, the other embryos are still yours. They're going to sit here and wait for to become a sibling a couple years down the line. So when you come back, it becomes very straightforward to do a frozen embryo transfer. We just thaw the embryo, get your body at just the right time to allow for implantation. And that can be done either, as we said, by a fresh, or rather by a natural cycle or a medicated cycle, and then place that embryo back inside of you. So that's a fresh transfer. In just about every situation, a fresh transfer may be less successful than a frozen transfer. Why is that? Well, a fresh transfer is included in the price, and people do get pregnant from fresh transfer. So if you have enough embryos and you have the ability to do a fresh transfer, that is to say that the numbers aren't telling us bad idea, then absolutely go ahead and do it, because people do get pregnant. But you have to remember that your body has been in egg making mode, and egg making mode may not always be consistent with getting pregnant mode. And in that scenario, we may tell you sometimes the hormone levels come back such that a fresh transfer is not going to work. We don't want you to do it because we do not want you to waste an embryo. People often get upset when that happens because they had their heart set on doing a fresh transfer. It really has to do with your body. It's not a personal choice we make as to whether you should do it or not. It's whether we think it's going to work or not. And if it's not going to work, please don't waste an embryo. But that's a fresh transfer. And people say, well, and I've said this before and people laughed at it, but fresh vegetables are always better than frozen vegetables, right? You go to the grocery store, you don't want, green giant. Well, if you're taking that out of the frozen food section, it may not be as good as getting those snap peas from the produce section, right? Well, yes, That's true when it comes to vegetables coming off the farm. But when it comes to embryo transfers, again, egg making mode is just not always consistent with being pregnant mode. So a frozen embryo transfer would be when you take a break after your retrieval, or maybe you do a fresh transfer and it doesn't work. But sometimes people just choose to do what we call a freeze-all cycle, or they choose to test their embryos through PGT. And that is the embryos are frozen. You come back another month, like maybe the next month later, and we get the embryo back inside of you. So that's the difference between fresh and frozen. Which should you do? Well, it depends. If everything else is normal, you can certainly do a fresh transfer. If you're planning to do PGT, pre-implantation genetic testing on your embryo, then it has to be with a frozen transfer later on down the line. Let's see what we have here. Shannon tells us, it looks like Shannon Childress moving to our practice and very excited to start with CNY. We are glad to have you there, and hi to Kevin, who's also with us tonight. And let's see. Looks like Brandy Lynn is saying we have 10 more frozen embryos, all well graded. What options do we have when we're done having babies? What to do with the embryos since you don't want to discard them? And that's a great question, and it's an ethical issue that really often comes up, Brandy. And discarding an embryo after you have worked so hard to create them does seem like a hard pill to swallow. So what I would ask of you, my friend, is would you consider donating your embryos? There are so many wonderful people out there who are struggling. And as we talked before about fear and courage, folks who are struggling to face that fear and stand up to it with the courage to move on. What an unbelievable gift it would be, Brandy, to donate your embryos to someone in need. And that's what I would always consider you, always encourage people to consider. There are ethical and moral and legal personal issues that go in with that. Our team can help walk you through all of those things. But it's a great question and certainly a good problem to have. So thanks, Brandy, for asking there. I might add, you just had your CNY baby. Woohoo! Thank you for that. That is awesome. Looks like we're going to have time maybe for another question or two here. Crystal is asking, when in your cycle do you normally have your egg retrieval? So the process of stimulation for an IVF cycle is best when it is a minimum of 9 days of stimulation. So typically folks will have day one of their cycle and they notify us on cycle day one. Within a couple of days, by day, let's say day 3 or so, they'll do a baseline, which is an ultrasound and some blood tests to show that things are really at their base level so that you're ready to begin. Call it 9 to 12 days of stimulation, followed by a trigger shot, and then 35 hours later, you do your embryo transfer. So roughly speaking, it's about 2 weeks into your cycle. So it's roughly around the time that you would have otherwise ovulated. And if you're listening before, we talked about that proliferative phase of the cycle, typically 2 weeks, and then ovulation, and then roughly a 2-week or so luteal phase. So roughly about 2 weeks. Minimita is saying, my husband got COVID and we're supposed to start once cycle day 1 comes. Are we done this month as his supply may be depleted? Well, I can tell you from personal experience in friends who are doing egg freezing, there is definitely a difference in egg quantity and quality as a result of COVID. I have not seen the data as it pertains to sperm quality or quantity. However, if I had to just guess, I would say hold off for a month. And I think that probably is a better idea. So looks like we're going to be about out of time here. As I am fond of saying, infertility is not your book. That is not the title of your novel. It is not the story of your life. It is merely a chapter, and our job is to help you rewrite that chapter. Because when you open that book to read, it should be one wondrous story after another. And I sure hope that we can help to make that dream come true. So until next Tuesday, by the way, don't forget, register for the Pride Month programs. Look at the CNY Instagram bio site for where you can register for this Thursday's program with Brandis, next Tuesday's program with me. But until next Tuesday, when it's time for more Fertility with Fink and Friends, I'm Dr. Randy Fink, live from CNY Fertility in Colorado, saying thanks for being here. God bless and good night.